So just a big thanks to Margaret Wong for organizing this conference. If you can just ask any UCI student, the fact that you could park here and leave at the end of the day without a ticket is just huge. So thank you, Margaret. But I thought I'd give the local perspective on these changes that are happening at the federal and state level and what they might mean to CalOptima, to our provider partners, and to all of the members that we serve. And I think more specifically what you've heard from this panel is there's a lot of focus from the feds, from CMS, and from the State Department of Healthcare Services on integration and coordination of care. And so I'm just going to highlight some of those initiatives that CalOptima has or will be implementing so that you as our provider partners in the room sort of know what's coming down the pike. And the initiatives that we're implementing are focused on seniors, on children, and on high-risk, high-utilizing members. And you're going to keep hearing about those members. And then last, Cindy asked me if I would just say a little bit on delegation oversight because of the recent situation in California with a large management services organization that has impacted more than 600,000 Medi-Cal beneficiaries, fortunately none in Orange County. So I think many of you here are sort of familiar with CalOptima, but we cover 1 in 4 Orange County residents, or nearly 780,000 individuals. Our programs include Medi-Cal for the low income, a Medicare Advantage special needs plan, a DSNP for the dual eligible population, a Medicare Medicaid plan called CalMedi Connect in California, also for dual eligible individuals, and then a PACE center that is located here in Orange County in the city of Garden Grove. So CalOptima has been focused on seniors. Our goal is to prevent or to delay seniors from needing to be placed in costly long-term care facilities. What we find is this is consistent with the wishes of most seniors in our community who want to live independently, who want to stay in their homes and stay in their communities. So our philosophy at CalOptima is that the more options we can create for seniors in front of or in place of long-term care, the better for member satisfaction, the better for quality of care, and it's better for cost. So one of the things we've done is in 2013, CalOptima opened a PACE center. And a PACE center is for frail seniors who qualify for placement in a skilled nursing facility but want to stay in their communities. A PACE center is basically the combination of an adult day healthcare center that they now call CBAS with an attached primary care clinic. So we pick up seniors in the morning, we take them home in the afternoon, and while they're at the center, there are social activities, there's occupational and physical therapy, there are on-site nurses and physicians, and there are meals. But really the heartbeat of PACE is the interdisciplinary care team, because we're focused not only on the services they receive when they're at our PACE center, but we're responsible for all of their care. So our interdisciplinary care team is focused on their primary care, specialty care, any hospitalizations, any visits to the ER, transportation, social services, care in the home. And what we're doing now at CalOptima is we're expanding access to PACE. So we're going to surround our PACE center with 5 satellite sites. And the 5 sites are all established adult day healthcare centers out in Orange County. So our PACE participants who choose to take advantage of this will be able to go to their neighborhood adult day healthcare center on most days and come into our PACE center as needed to be seen in the clinic by nurses and physicians, which currently we partner with UCI. So I think what we'll get with this model of satellite sites is that what we hope is that our PACE participants will have more choice and convenience to better meet their unique needs and preferences, especially related to culture, location, and medical conditions. So a lot of these adult day healthcare centers, some of them really specialize in certain parts of our community, certain ethnic communities, certain languages. We're also working separate from the satellite sites. We're also working to obtain federal and state approval for community-based physicians. So one of the barriers to enrolling these frail seniors into PACE is that it's all-inclusive. So that's the advantage, but it can also be a disadvantage for some folks, especially for those seniors who have long-standing relationships with their primary care physician, and they don't want to give up their PCP to join PACE. They don't want to use the PCP at PACE. So we're seeking a waiver so that we can use PCPs in the community to serve our PACE participants. And I think the bigger picture with PACE is that what you see with PACE is that it's evolving beyond the four walls with this idea of satellite sites that they call the alternative care setting model, this idea of using physicians in the community. I think the feds and the state see a lot of value in PACE, but that the value is really built around that interdisciplinary care team. And so maybe we can start thinking about PACE less about the four walls and about that specific center and more about the community and giving these frail seniors more choice and convenience, which is helpful to their families. Also for seniors, in 2015, CalOptima launched a Medicare Medicaid plan. And so this is it's called CalMediConnect in California. It's for those dual eligible individuals or for low-income seniors and the disabled. So the CalMediConnect plan combines the Medicare and Medi-Cal benefits into one single program. This was a program, CalMediConnect, that was at risk, but the 11 participating plans, including CalOptima, went to Sacramento. We met with the Department of Finance, and we showed the Department of Finance that even though this was a pilot program in its very early stages, that it was trending in the right direction to save the state money. So Governor Brown gave the program a 2-year extension until the end of 2019, and I think all of the plans are confident that we're going to be able to show savings to the state, to the Department of Finance, so that it will be extended even well beyond that. And so I often, sometimes I get asked at CalOptima, why do you have two different programs, your Medicare, Medicaid plan, and your DSNP for dual eligible individuals? Is there a preferred program? And the answer is certainly yes. It's the Medicare, Medicaid plan, since it's one program that combines the benefits. But the fact is that there are some seniors that are not eligible for the Medicare, Medicaid plan. And so that's why we leave our DSNP open. We have about 1,500 seniors in our DSNP. And so we don't want to pull the rug out from them. They've been in that program for years, and we want to take care of those seniors. So CalOptima is also focused on children. We have a long history, a long track record of serving the needs of children that goes back 20 plus years. And so the state of California is now asking CalOptima to take more responsibility for children in the CCS program. And so preparing for this transition is one of our top priorities for this calendar year 2018. The transition will become effective on January 1, 2019. And so today, if you look at this CCS program, as JC mentioned, it's a bifurcated program. So the County of Orange is responsible for the child's CCS condition. CalOptima is responsible for the same child's non-CCS conditions. So this bifurcated system, two parallel delivery systems, creates a lot of obstacles for families of these children, a lot of obstacles for providers that serve these children. And so that's the reason for what they call the whole child model, to combine the responsibility for the CCS and non-CCS conditions with the managed care plan with CalOptima. Let's just think about the whole child instead of their conditions. So there are 13,000 children in Orange County in the CCS program. These children are currently served by many of CalOptima's contracted providers, including our health networks, including facilities like CHOC, UCI, and Fountain Valley Hospitals, just to name a few. And so our goal at CalOptima will be to work with our provider partners to ensure a smooth transition for these children and their families, and to create a better, more integrated system of care for all of us, for the children, for their families, and for our provider partners. And so, under the whole child model, the only part that would be left behind with the county would remain the eligibility. So the county will continue to determine eligibility for the program, and the county will continue to be responsible for the medical therapy units, that physical and occupational therapy. But otherwise, CalOptima will have responsibility for the CCS and non-CCS conditions, and providers will work directly with us, and CalOptima will pay claims. So, in 2019, CalOptima will launch a health homes program, and the program will target the top 3 to 5% of our highest risk, highest utilizing members. Members will be identified by chronic physical conditions, by substance use disorders, and by serious mental illness. The group will be further narrowed by those who have had a recent inpatient stay, those with multiple ED visits in a year, and those who experience chronic homelessness. So at CalOptima, we think of these people as being the people with the greatest needs, the people with needs that go well beyond any one county agency. Their needs go beyond any one health plan, beyond any one provider, beyond any one community-based organization. And so I think what happens with these folks today is that everyone's responsible for taking care of these folks, and yet nobody is really fully responsible. So with these are the people who we think could benefit the most from integrated, coordinated care. And the Health Homes program will coordinate their full range of services across physical, behavioral, and social services. So that takes me to delegation oversight. And I'd just say that regulators now have a heightened focus on delegation oversight, given the recent failure of a large management services organization that, like I said, has impacted more than 600,000 Medi-Cal beneficiaries in California, fortunately none in Orange County. And so there's a strong delegated model here in Orange County, and CalOptima has some experience with delegation oversight. 5 years ago, CalOptima was sanctioned by CMS. The sanction was largely related to our level of delegation oversight. Concerns were that members were inappropriately denied services by our delegated entities, that members were made to wait beyond required timeframes for authorizations, that members weren't made aware of their rights to appeal. And so CMS gave CalOptima 1 year to fully remediate the issues across these 13 different organizations. And so CalOptima and our delegated entities experienced that 1 year in 3 different phases. So when I first, based on my trips to Baltimore, to CMS headquarters in Baltimore, so when I first traveled to Baltimore, the head of oversight and enforcement at CMS said that expressed serious doubt about the delegated model, about CalOptima's ability to oversight the delegated model, and about CalOptima's participation in the Medicare program. So I came back that year, and during the first 6 months of that year at CalOptima, we built a new audit and oversight department, established audit protocols, audited all of the delegated entities, issued corrective action plans, completed training and education, and met with the senior management of our delegated entities on several occasions. So in the summer, I went back to Baltimore for my second visit with CMS. And on that visit, I explained to the head of oversight and enforcement all of that work that we had done. And the response from CMS is, it's not about effort, it's all about results. And the truth was, through all of that work, our delegated entities hadn't moved the needle, that they really hadn't responded in a material way to those corrective action plans. So left with sort of no other option, what we did is we started to establish significant financial penalties for any open corrective actions. And that was sort of the final catalyst that really moved the needle. Two of our delegated entities quit, and all the rest got on board. And really within the next month, I would say we moved the needle from almost nothing to 80%. And then of course that last 20% was the hardest, and that took a few more months, but we got there. So in the last 3 months of that year, we were really focused on sustaining those improvements, because when CMS sanctions you, they don't take your word for it that everything's been fixed. They come back for a second audit. And so we had an army of CMS auditors come back and audit CalOptima and our delegated entities, and we passed with flying colors. I would just say the delegated model works, but it requires good delegation oversight, and that delegation oversight is all about protecting the interest of our members. But I think what we developed through this experience is a better delivery system that's much more responsive to our CalOptima members. And I would just say about the delegated model that it works. CalOptima, NCQA, the National Committee for Quality Assurance, has rated CalOptima the #1 health plan in the state for the Medi-Cal program based on the quality of care that our members receive. And so that's an appreciation to all of our providers. And, so thank you for that.
Yeah, thank you.
Uh-huh.
Thank you. Wonderful.